Thanks for coming up anyway and coming to visit us at the Conway Institute. I suppose in my lab with Aidan, we're working on pancreatic cancer. So, Peggy, you've been involved in our work for a little bit. We've sent you some stuff to look over. Since we've chatted, I suppose it's really nice to meet you in person, put a face to the person on the other end of the phone, which is lovely. So maybe you'd like to tell us to start with, just a bit about your journey to this point.
Thanks, Stephen. Yes, I was diagnosed in October 17 after feeling unwell, a lot of stomach trouble, and my GP sent me to a gastrosurgeon in Galway, which he did a scan, and there something showed up, which I was on the road into Vincent's. And after that, I started on the long road. And that's what I was saying. Any research is so welcome. I didn't realise that and how important it would be. I had chemo starting in December and radiation starting in April. And presumed I'd have an operation after that. Didn't work out. That plan didn't work out quite as I expected. The tumour hadn't reduced enough, so the radiation had caused some difficulty, some bleeding in the stomach. So it was the following December before I got my third radiation, and about the beginning of March, they did a scan, and great. I was called for the operation, not knowing how. By the way, in the middle of all this, I hadn't realised how long the journey was or how difficult it was going to be. Yeah. But I learned that from a booklet in a Sheeveen in Galway, in the radiation.
Which you didn't look at until a long time in. Yeah.
Oh.
Yeah.
And look, as soon as I got the results of the scan, I was called. My surgeon, Dr. Hoti in St. Vincent's, and called for the operation. Right. And after the operation, he came in and told me it was gone.
Great.
And I didn't have to have any treatment or anything after that.
Oh, no treatment afterwards?
No
treatment.
How
did that feel?
I felt so good. Now, it wasn't a quick recovery. The healing was okay. It's just there was a lot of stomach problems and things afterwards, but they weren't cancer related. So it was great. And it's only then I started thinking, like, my goodness, the research. I remember my surgeon saying to me, some years ago, we wouldn't be having this surgery.
Yeah.
And I was so grateful for all the research that had been done. I hadn't realised it. I hadn't been thankful enough for it. But anything I could do to help with research after that, my goodness, I'd be only too delighted to help.
Thanks for sharing the story. Have you any questions for Aidan and myself about what we're doing?
Yeah, I know you're doing research, both of you. So could you tell me about your research into pancreatic cancer?
I suppose I'll start. So I have a lab here in Conway Institute, and we work on mostly pancreatic cancer in the lab. That's what most people in the group work on. And I think there's 6 or 7 of us in the group, and we've got projects looking at different aspects of it. So Aidan will tell you a bit about his stuff in a minute. He looks a lot at sort of understanding the tumour. And then we've got other projects in the lab looking at trying to target the tumour so we can develop new targets for treatment. So we're kind of looking at it from 2 ends, really. Understanding it better and then using that to hopefully come up with ways to treat the tumours better. So that's a bit about what I suppose the group does. Aidan, you want to talk a bit about what you do?
Yeah, so thanks again for being here. I'm Aidan. My background is I'm a doctor. I'm sort of halfway through my surgical training, and I've taken time out now to do a PhD in pancreatic cancer. One of the things that we're looking at, what you sort of were speaking about there, about the fact that you got your chemotherapy and then you had your surgery. And that is something that's that's one of those things that's sort of only happening in the last sort of 10 years or so. Which is probably why Mr. Hoti would have said that to you. It was one of those things that you got your scan, and if your cancer was in a certain place or a certain size, then you were a yes or no for surgery, and that was it really. Whereas now there's a grey area that we're sort of looking at a little bit more, that it isn't just, yes, you can have surgery, or no, you can't have surgery. It's, well, why can't you have surgery? And is there any way that we can try and give chemotherapy to make your tumour more amenable to surgery? At the moment, surgery is the only sort of cure for pancreatic cancer, but still sort of only less than 1 in 5 people that get diagnosed with pancreatic cancer are getting to surgery, because people present so late and because it's so hard to treat. Instead of about 10 years ago, there was no one really that had pancreatic cancer that was getting chemotherapy before it. Now about half the people that are getting their operations for pancreatic cancer are getting chemotherapy before it, to try and get more people more numbers in, more people operated on, and give the most people a chance to be where you are today, basically. So one of the things we're looking at is, even though we've started giving this chemotherapy, we're not really 100% sure what it's actually doing to the tumour. Now we know that, and from Dr. Thorpe's working, previously, and with other people in the lab, and from other research outside of the group, one of the things about pancreatic cancer is that you can have a very small tumour, but then you can have a very big reaction around that tumour in your pancreas that can be rock hard. And the main thing it lays down is collagen, which is sort of the thing that would be at the tip of your nose or in your ear, like that. A lot of the time when we think about sort of bad lumps and bumps, if they're hard, then often we can think of them as bad, and we think it's the same with the pancreas, that the harder the lump in your pancreas, the harder it can be. And that's one of the things I'm looking at to see sort of, does that actually match up? So we're looking at patients that have that are getting operations for pancreatic cancer, and we're seeing we're doing some investigation to see how hard or soft or stiff that tumour is, and then comparing it to how patients are doing. One of the things we're doing with people that are, when they're getting diagnosed, so they might get a camera test down into the stomach and a biopsy taken that way. What we're doing is we're taking an extra biopsy from there, and then we're going to see the same patients, and the same patients that if they get their operation, get an operation to get that tumour out, we're going to see how, and if they get chemotherapy, how does chemotherapy change the pancreas? So what we think is it probably makes it softer, because we want softer tumours. That's what we think makes things, people do better, but we really don't know. So that's what we're planning on doing here. So we're taking down in Vincent's, 2 of the consultants are taking when they get their biopsies to diagnose the tumours, they're taking an extra biopsy for us. We're testing stiffness of that, and then we let the patients get their chemotherapy, and then afterwards, when they come back in 6 months or 12 months or whatever, that we take it when they get their full operation like you would have had, then we take a part of that pancreas as well, and we test the stiffness of that and see how the stiffness has changed.
Okay.
Yeah.
And what are the causes, I wonder? What are the risk factors that we should look out for, everyone should look out for?
Yeah, I suppose pancreatic cancer it's not that common, thankfully, but people who get it don't do well. And we currently, it's probably, you can expect if you're diagnosed with pancreatic cancer, you're doing well to live beyond a year, and only about 1 in 10 live, beyond 5 years. So it's really quite a poor prognosis. And the causes really are, causes are common across a lot of cancers. So that's the thing. There's not really things that are unique to pancreatic cancer. Things like obesity, smoking, a lot of alcohol, and I suppose diabetes to some extent can be a risk factor as well for pancreatic cancer. These are all things that are very common, and none of these things mean you're going to get pancreatic cancer. So there's a lot of people with all of these things and don't ever get cancer. So it's very difficult to really identify patients who are very likely to get it. Now, there are one instance, I suppose, where they screen is where you might have 2 relatives in your family who've had pancreatic cancer who are close relatives. It's pretty much the only group really that's screened at the moment. And one of the things I suppose we're looking to do as part of an upcoming project is to actually look at better ways of understanding who's going, can we broaden this field a bit in terms of screening people, maybe people who get diabetes alongside some other, weight loss at the same time. That's one kind of group we're looking at as a potential group that may be worth screening, but it's very difficult because you're screening a lot of people for very few potential cases. So it's hard to patch it off. what the best approach is, or if there is even a good approach. And the other thing we need is a good test. So how do we actually test for pancreatic cancer? Can we do it a bit more easily, or do we have to send someone for a CT scan? Which again will only show the tumour if it's relatively big. It's really at the very beginning you mightn't see it. So there's a lot of challenges there, and that's one of the big issues with it, I think.
Now, maybe you covered this before. Why is it so hard to treat it? I think you kind of covered it now, did you?
Yeah, so there's sort of two reasons why it's so hard to treat, really. I'm sure when you went to your GP, first your GP wasn't saying, well, this Peggy definitely has pancreatic cancer. People can push off these symptoms for a long time. You can say, oh, I've got a bit of indigestion today, I've got a bit of back pain, I've got a bit of this or a bit of that. Exactly. It's all of the symptoms you can get. Pancreatic cancer is never the most likely reason for any of those symptoms. And we all get all of these symptoms at some point. And that's why it can be hard to nail it down and to treat it. So that's the first part, that once you get there, it's hard to get a diagnosis. And then the second part then is that the tumour itself can be very hard to treat. So that's can be for a number of different reasons. As we said, first of all, surgery is the only cure so far. And just because of the location where it is, it's in an awkward place. It's right behind the stomach. It's right across a lot of the important nerves and vessels and things inside in your tummy. And even if it's a small tumour, if it's in the wrong place and it's near important arteries, then unfortunately there's very little you can do. But even if you do get to surgery, or if you can't get to surgery, then other treatments like that you would have had before, and the chemo and the radiation, they only work in a certain amount of patients. It's still sort of hard to figure out who does well and who doesn't. That's one of the things we're hoping to look for with the people that once we look at their biopsies and they have their chemotherapy, and then we see afterwards and we see the changes, we'll also be able to see those patients and see, did their tumours actually change? Did the tumours soften and did their tumours get smaller, or did their tumours not soften and their tumours got bigger? We don't know. But that's what we're hoping to find out a little bit. What we know is that from other studies is that the harder the tumour is, the more collagen there is, the more things, and collagen is really woven and sort of tightly knit like that. The more that it is there, the harder it is for us to give chemo to actually penetrate that tumour. So you'll have your tumour, your tumour will be might be a small little dot in the middle, and then there's this big huge lump of collagen around it. And we can pump as much chemo as we want to it, but that collagen will never let the chemo get to that tumour. And that's one of the things that can be so difficult with pancreatic cancer, is sort of a bit unique to pancreatic cancer sometimes as well.
Okay, so I was going to ask you, what is your research? That's what your research does. That's answered. Yeah. I never heard of that before, about this hardness to get into the actual tumour.
Yeah.
With no wonder the chemo sometimes doesn't work.
Exactly. Yeah.
My goodness, it's no wonder. There was something else now. And challenges. What are the hardest? Money? What else?
Yeah.
In your research?
Yeah. Running a group, it's money really. It's money and people. The ultimate goal is to help people, and to help people either, I think most of the work we do is focus more on treatment, so treatment from people like you who had pancreatic cancer, who present, how do we treat these tumours better? Because people present late and we want to be able to help them. And a lot of what the lab does is we work on two ends of it. And the ultimate aim is to develop better approaches to treat these tumours. And like Aidan described, the collagen we think of as a cage around the tumour. So cages can keep things out and keep things in. So it can keep the cancer in to some extent. It also keeps the drugs out, which is bad. And we want to look at how do we break down that cage. But you have to be quite careful about how you do it, so the cancer doesn't escape. That's a bad thing, and that's been a problem where they've, early trials in this sort of area, maybe 10 years ago, using new treatments, they tried to get rid of the collagen cage, and then the cancer spread, and they had to stop trials early because they were really having negative results. And this is a big issue because they did this work in mice, and it worked really well. And then when they brought it into humans, it was very different. So there's a lot of kind of challenges around how we do this. What we're focused on is targeting specific cells that are in there, not cancer cells, but other cells in the that are in a normal pancreas, and they're still there in the tumor, but they're kind of misbehaving in the tumor, if you want for a better word, and that's what we're really quite focused on in the group.
Yeah, and I was saying to Francis, the researcher, before you come in, it's all the links. Like, I went to the GP, Dr. Cowley sent me to the gastro, Dr. Cost, the gastro the surgeon in Galway, my oncologist, Dr. Leonard. They all were a link into it. They were all links that helped, and at the back of all those links were the unseen faces that the patient doesn't see, were the researchers that was working so hard in giving them the information to know. Like, my GP saw my tan, knew it wasn't a tan. So things like that, they're told to look out for, which was all due to research.
I think actually a good example of that is Aidan's project, where Aidan, you maybe can tell there's different people involved in terms of how we were working with in the hospital, just to make this happen even.
Yeah, so it's like at the even just down in the hospital, there's probably there's all of the surgeons that are operating, they're all on board. They're all happy for anyone who's having the operation that you had, that they give part of that they donate part of that pancreas once it comes out to my research. And then people who are getting those biopsies beforehand, we've got 2 consultants when they're doing those biopsies to do that. We've got a pathologist that's up there that looks at things under the microscope to be able to tell us, well, this is tumour and this is stroma and this is normal pancreas and this is where you should do your testing on. And then we've got sort of another 2 or 3 people up in the actual lab itself who are sort of scientists up there who, once the pancreas comes out of the operation and out of the operating theatre and upstairs to the lab, they cut it up for us. And sort of prepared for the consultants for them to look at it under the microscope, and they prepared for me as well to do my investigations on. So there's almost a dozen people down there, and then all the nurses as well that are involved, just to sort of get the specimens up here, and then probably God knows how many up here that are involved.
That's what you've been doing with my pancreas. Are you going to ask for the public health than anything?
Yeah, so I suppose any clinical research now, just to get funding, you need to have patient involvement, patient and public representative involvement, and that's something, I suppose with Aidan's project, we're talking to you, and I've sent you some things in the past, some little very short synopsises of projects that you've looked at. You're very kind to give us a bit of feedback on, and that's the kind of thing, I suppose, that's the start of it really. And I think where for the translational work that's getting towards trials, not necessarily clinical trial work, but certainly work that we've been doing towards that. So maybe sort of the next iteration of Aidan's project might be a trial, for example, that might look at testing patients' stiffness, tumours, how stiff they are, or their biopsies, and then maybe trying to decide what the optimal treatment is after that. So that's a key output that Aidan's project might lead to, is that we might be able to better predict what treatment's going to help that person. And if we had to do a trial on that, we'd obviously want patients involved. So we know, first of all, what their experience was, what didn't work for them, what did work, and how we might design the trial to suit the patients better and help them. So that's the kind of thing where we really need patient involvement. But also in this earlier stage, it's really useful just to help understand whether we're answering the right questions. Are we dealing with things that matter to patients, or are we just doing something because I think it's an interesting science question and we're like, oh, we can do it in pancreatic cancer? But we do need to keep the fact that it's about answering questions that help patients at the front of our minds. And I think by having patients involved and hearing their stories and hearing what they've gone through, and that helps us keep that focus. I think that's the key thing, really.
You're amazing now, both of you.
So are you.
Do you know, Stephen or Aidan, what is a trial really?
Well, you can go ahead.
I suppose so. A trial is, and there's not enough trials in Ireland. That's a big problem in Ireland. In that, if you're in, I'll explain what a trial is like. But if you went and presented with your symptoms and you were going for cancer treatment in America, in the United States, you would very likely in many hospitals be offered the opportunity to go on to a clinical trial. And clinical trials have been shown, patients on clinical trials, even if they're not getting the clinical trial treatment, tend to do better. This is a fact. In Ireland, we have very few clinical trials. It's something they're really working on as a cancer research community to try and build more trials into more options so that when people present with cancer, they have an option of a trial if they want to. A trial is essentially, it's a new treatment. It could be a new surgical approach. It could be a new drug treatment. It could be a new medical device. But essentially, these are scenarios where your treatment pathway will be altered slightly by potentially having this new treatment instead of the old treatment that was conventional. So one of the big areas we're looking at now is, and these trials aren't yet happening in Ireland, but across the world in pancreatic cancer, is giving everybody neoadjuvant therapy. So giving everybody chemotherapy before surgery, even in those people who don't need it necessarily, because they think you have better outcomes if you have it post-surgery. So that's a really interesting new development. There's other areas. Is radiotherapy really useful for everyone? And there's potentially questions around, is it or not? And there's really, there are trials going on looking at that, because some people respond and it's really helpful, but a lot of people don't really get any benefit from it. And as you said, you did a lot of stomach bleeding. It was quite uncomfortable. So you'd want to know that was doing something worthwhile for the hurt it causes. So I suppose these are two big areas where there's a lot of work, trials ongoing at the moment. Do you want to add to that, Aidan?
I think you got it all there. Yeah.
There's no new, okay, that's just having it before instead of after. Yeah. Is there any new drugs or anything new?
So there's one
coming up.
There's one I should describe, which we've done some work on. So I worked on this bit in the past, and actually we even did a little bit of work last year on this drug. And this is a drug that it targets that collagen that cages the tumour. And that's currently in phase 3 trials in England. So there's a guy, a surgeon actually in London, who's leading that trial. And it's this drug, the idea is that you give the patient this drug, it basically breaks down the cage around the tumour, and then you give the patient the chemotherapy, and the chemotherapy is more effective at shrinking the tumour. So that's one that's looks really promising so far, and it seems to be going well. And it's essentially just vitamin A. It's not a crazy fancy drug, it's just a form of vitamin A. So
that wouldn't take years to make safe.
It's approved already. It's not, doesn't really require approval. It's more about repurposing it for this thing. Now the challenges with this are, because it's approved and because it's not a fancy pharma drug, it's actually quite hard to get the trials over the line, because you don't have a pharma company who's going to make a massive amount of money out of this. So the trials tend to be funded by charities or
for the farmers. They're selling the carrots, I suppose.
Yeah. Well, that's true. Yeah, good point.
Yeah, might hit them for some money. Yeah.
So immunotherapies have had really poor success in pancreatic, and that's because, the stroma, the collagen. The collagen is a big problem, and then the collagen around the tumour, and then the other aspect of it is there's very few immune cells. The only immune cells in a pancreatic tumour tend to be immune cells that prevent all the other immune cells from working. So there aren't really cells that can interact with immunotherapy. So that's why immunotherapy has had such poor success. Now, treatments like the one I just described, which targets the collagen, they may help get good immune cells into the tumours, which may actually mean immunotherapies might start to work. But they'd have to be in combination with other treatments.
Thank you so much for coming up to us, obviously, and it's you and patients that are the most important thing really in this. We're sort of nothing without you. And like, you're so generous with your time, and all the people that are involved that have donated their part of their pancreas to my research. Like, I think I've in the last sort of year and a half, I've spoken to about 80 patients who are going through the operation that you went through. And not a single one has said they don't want to be involved in the research. Every single person is just whatever needs to be done, or whatever can be done. Which is just makes life so much easier.
Yeah, they did ask me in St. Vincent, so I did donate my whatever they took away.
Yeah, thankfully we're here today. Thanks to Breakthrough Cancer Research, and they co-fund Aidan's project, and that's allowed Aidan to do this hopefully what will be really impactful work. And we've high hopes for this, and I think it's going well so far. So it's looking good.